neuroradiological imaging. And for this month, we'll be looking at neuroimaging in epilepsy. And for this session, we'll be having a seasoned lecturer who will be delivering this lecture to us. I'll be reading his profile. He's Dr. Richard Efidi. He's a diagnostic radiologist at the King Khalid General Hospital in Saudi Arabia. And he obtained his medical degree at the University of Ibadan and postgraduate fellowship in radiology at the University College Hospital, Ibadan. He's a fellow of the Medical College of Radiology and the West African College of Surgeons. Dr. Efidi has several publications in local and international peer-reviewed journals, which the majority of his research works focused on neuroradiology. Let's make welcome Dr. Richard Efidi as he delivers his lecture. You're welcome, sir.
Thank you very much for that nice introduction. And once again, I'm sorry for the delay due to some technical issue I had. So I would now like to share my screen.
Go ahead, sir.
I hope you can all see my screen. So,
yes, we can.
All right. So I'll be presenting neuroimaging in epilepsy, and I'll be following this guideline. We'll look at introduction, then a brief physical principle, the role of imaging in the management of focal epilepsy, the categories, and the common etiologies of focal epilepsy. We'll also look at the diagnostic workup of medically refractory focal epilepsy, MRI detections, the role of advanced modalities, and multimodality integration with image processing. So by epilepsy affects up to 2% of the world population. That's staggering 70 million people, which makes it very important. Up to a third or close to a half of this epilepsy patient on anti-seizure medication go ahead to develop medically refractory focal epilepsy, despite the advancement in therapeutic development. Multimodality imaging approach actually plays a role in optimal diagnostic workup and management of drug-resistant epilepsy. And more than half of these cases actually go ahead to achieve seizure freedom after surgical resection of the epileptic focus. MRI plays a central role in the imaging work of epilepsy, being the workhorse in the modality. So we'll briefly look at the physical principle. So as a result of the odd number of protons in hydrogen nucleus, which gives it magnetic property, and also as a result of its abundance in the human body, the hydrogen nucleus is of special interest in MRI imaging. Now, the basic principle can be summarized in these steps. Usually, the hydrogen protons or spins actually possess what we call spins, which are randomly oriented in the human body. So when the body is placed in a magnet, in an MRI magnet, two things happen. The spin become aligned in the direction of the magnet, even though some also get aligned in the opposite direction, but there is a net alignment in the direction of the magnet, which gives it what we call the longitudinal magnetization. So the second step now involves introduction of the RF pulse. The RF pulse does two things as well. The RF pulse actually transfers energy to the precessing protons. By transferring energy, the protons moves from the equilibrium or low energy state to the high energy or excited state. So in the process, their longitudinal magnetization is changed, is converted to what we call the transverse magnetization. Now, the other process, when the RF pulse is withdrawn, then the energy absorbed by the spins are re-emitted or retransferred to the environment, and is in turn absorbed by the RF coil, which is now used for MR imaging. Now, during this process of RF transfer of energy from the spins to the RF coil, two things occur. The relaxation process occurs, and there are two relaxation processes. The T1 relaxation process or longitudinal relaxation process and the T2 relaxation process. The T1 relaxation process involves the regrowth or the regain of the longitudinal magnetization that was initially lost when the proton absorbs energy from the RF pulse. And this regain of longitudinal magnetization occurs slowly over time, and it occurs at different rates for different tissues of the body. The second relaxation is the T2 relaxation, or the transverse relaxation, which involves the loss of the transverse magnetization that was gained during the process of excitation. And this also occurs with time at different rates for different tissues. Now, the difference in the rate of the transverse and longitudinal magnetization is actually what we use in forming our MRI contrasts in the image, in the MRI image. Now, for instance, the T1 relaxation, since it varies among tissue, we can use it to generate the T1 weighted image, which is based on the T1 contrast. So if you look at this T1 relaxation curve that shows regain of longitudinal magnetization, for instance, in the brain, we can see that the rate of longitudinal magnetization for CSF is lowest, whereas that of white matter is highest. So using the parameter called TR, or time to repeat, which is a parameter we use to control T1 contrast, we can actually set the TR time short so as to capture the maximum contrast between this part of the brain. So if, for instance, we set it at this point, we can see that the structure that has the highest signal will be the white matter. That's why the white matter is white or high signal. Okay, so I was talking about the longitudinal relaxation curve and the fact that the different structures of the brain have the different rate of longitudinal relaxation, and that is what is exploited in T1 contrast, which is we see in T1 weighted image. So because the relaxation rate for CSF is the lowest, at this point, if we capture the image at this point using a short TR, which is the parameter used for controlling T1 contrast, we'll realize that CSF has the lowest signal here, because this represents the signal intensity. And that's why CSF is black on T1 weighted image. The white matter has the highest signal because it has the highest rate of recovery, and hence its signal intensity is maximum. And that's why white matter is white on T1 weighted image. And then the gray matter has intermediate signal. Now, in achieving T1 contrast using a short TR, we also need to use a short TE, because TE is used for controlling the T2 contrast. So in trying to achieve T1 contrast, we need to maximize T1 contrast using a short TR and minimize T2 contrast using a short TE, which we are going to see in the next slide. So this is the T2 relaxation curve. And T2 relaxation shows the rate of loss or the rate of decay of transverse magnetization. Now, just as CSF has the slowest in recovering its longitudinal magnetization, it is also slowest in losing its transverse magnetization. If you look at this curve, using the TE parameter, which is used for controlling T2 contrast, we usually want to use a long TE because that's where we get the largest difference between the structures of the brain. So using a long TE, we can see that the CSF is still showing high signal intensity. That's why CSF is white on T2 weighted image. And of course, white matter, which is also the fastest in gaining long-term, is also the fastest in losing transverse magnetization. So that if we capture the image at this point, we can see that the white matter has the lowest signal. And that's why the white matter is dark on T2 weighted image. So in achieving a T2 contrast, we use long TE. But we also need to use long TR because long TR we obliterate the T1 contrast. We don't want to have the two contrasts in one image. So when we are trying to achieve T2 contrast, similarly, just as in T1, in the case of T1, we need to maximize T2 contrast itself by using a long TE. And at the same time, we need to minimize T1 contrast by using a long TR. Then we also have the proton density image, which shows the difference in the proton concentration. So in achieving a proton density image, it means we need to minimize T1 contrast, which means we are going to use a long TR. And we also need to minimize T2 contrast, which means we are going to use a short TE, so that we only have proton density contrast, which we appreciate on our proton density image. So this is just a short overview of MRF principle. Now, what is the role of neuroimaging in management of epilepsy? Neuroimaging is essential for etiological diagnosis, and this will determine the kind of treatment we are going to give. And neuroimaging is necessary for localization of epileptogenic focus or zone, especially in non-lesional epilepsy, because the detection of the detection and the localization of the epileptogenic focus is crucial for successful surgical resection. Now, the neuroimaging is also important in determining the feasibility of surgery, especially in those patients we consider to be surgical candidates, and then necessary for pre-surgical assessment and prediction of surgical outcome. Anatomically, epilepsy or focal epilepsy can be classified into three groups. Here is the temporal lobe epilepsy, which are usually localized in temporal lobe. The extratemporal lobe epilepsy, in which lesion is localized in another part of the brain outside the temporal lobe. And then the non-lesional, or what we call the MRI negative epilepsy. This is important because that is one we tend to miss. So there are two scenarios. Is either it is so subtle that we commonly miss it, physicians commonly miss it, or it is not detectable at all, or structural MRI, structural imaging. And this accounts for a substantial proportion of drug resistance epilepsy, which is important because this patient will need surgery. Now, there is also the etiological classification of focal epilepsy. And the common ones are what I illustrated here. Usually, mesial temporal sclerosis and focal cortical dysplasia, which is a malformation of cortical development, tend to be the most commonly encountered lesions in the daily routine of radiologists. There are also other causes of epilepsy, including the long-term, the epilepsy-associated tumor like DNET, vascular lesions, especially the cavernous malformation, then post-traumatic lesion, infection or inflammatory causes, such as limbic encephalitis, bacterial abscess, then other causes too, like hypothalamic hematomas and Sturge-Weber syndrome. Hippocampal sclerosis, which is the most common form of mesial temporal sclerosis, tend to be one of the most common causes of treatment-resistant epilepsy and also MRI negative focal epilepsy. The characteristic feature is actually hippocampal sclerosis is characterized by hippocampal atrophy, which is the most specific MRI characteristic. The other one, common one, is increase in T2 or flare signal. So we can appreciate in this coronal a coronal T1 image, this region of hippocampal sclerosis, hippocampal atrophy on the left. And in this same hippocampus is showing a T2 flare hyperintensity, which can also be appreciated on the axial image. Focal cortical dysplasia actually accounts for up to 80% of pediatric drug-resistant epilepsy, and it has characteristic features on MRI. There are actually 3 classes of focal cortical dysplasia. The most common class that is mostly encountered is the type 2. Now, the characteristic of focal cortical dysplasia on MRI includes subcortical hyperintensity, which can also give what we call the transmantle sign, in which the cortical hyperintensity extends towards the ventricle. And then there's also the focal cortical thickening, blurring of the gray-white matter junction, as well as cortical hyperintensity. So in this coronal T1 weighted image, we can appreciate this area of cortical thickening in the left frontal cortex, which appears as T2 flare hyperintensity. And usually this subcortical hyperintensity gives rise to what we call bottom of sulcus sign, which is common in a subtype of focal cortical dysplasia type 2. There's also the nodular periventricular heterotropia, which usually occurs as abnormal location of gray matter around the ventricle, as you can see in this coronal T1 weighted image. And then there is also the polymicrogyra, as you can see, which shows multiple small gyra, okay, in the pericevian fissure in these 2 images. And the tuberous sclerosis is also a common cause of epilepsy. And the T2 flare axial MRI here showing multiple cortical tubers, which is characteristic of tuberous sclerosis. And in the set of images on the right, we can appreciate the cortical atrophy and hypointensity, which appears as signal void on this susceptibility weighted image. This is characteristic of tuberous sclerosis. In this same patient, there is also a coexisting hippocampal sclerosis, which sometimes can occur in a patient being evaluated for epilepsy. The other type of etiological cause of epilepsy are the long-term epilepsy-associated tumor, which are also common cause. So the common ones that are encountered include the DNET and the ganglioma. These are solid tumors, so there is need to obtain contrast T1 weighted MRI. So this image, the T1 coronal MRI, is showing this lobulated multicystic lesion with an area of enhancement, which shows a solid component. These multilobulated multicystic lesions are usually characteristics of DNET. And then the image below shows a predominantly solid lesion with a cystic area, which is a case of ganglioma. Now, another important etiological cause of focal epileptogenic lesion is what we call meningoencephalosis. This is important because this is often missed. It's not a common lesion, but it's an important cause. So meningoencephalosis, as you can see in this image, involves herniation of part, usually of part of the temporal lobe, in this case, the right temporal lobe, into a defect in the middle cranial fossa. So meningoencephalosis is an important cause of focal epilepsy, but it is often missed because of its hidden nature. as you can appreciate in this image, which involves herniation of part of the temporal lobe into the middle cranial fossa defect. Then another important cause of focal epilepsy is limbic encephalitis, which also involves the mesial temporal lobe, as in this case, and sometimes it can be confused with focal cortical dysplasia, except for the fact that apart from hyperintensity, T2 hyperintensity, there is also swelling of the hippocampus. So this is how we differentiate it from focal cortical dysplasia. Then hypothalamic hematoma is also an important epilepsy, which characteristically causes gelastic seizure, which is classical. Then cavernoma is also an important cause of focal epilepsy. It's also an important cause of focal epilepsy and is best appreciated on susceptibility weighted image, as we can see, and it occurs as focal area of signal void, as in this case. Now, there are three categories of epilepsy-related lesions. There are the epileptic cotogenic lesions themselves, which have the potential for causing focal epilepsy, and they are in fact responsible for the cause of the focal epilepsy in the given patient. There's also the seizure effect, which are usually transient and usually occurs during seizure episode or immediately after seizure episode, like in this case of restricted diffusion on DWR. And the characteristic feature is that if we repeat this MRI, this will disappear after some time. Then the third lesion are the incidental finding, which also have the potential for causing epilepsy, but they are not responsible for the cause of epilepsy in the patient under examination. Now, this is showing the diagnostic workup of drug-resistant focal epilepsy is a chart. Now, the diagnostic workup of drug-resistant epilepsy actually involves two phases. The first phase is the use of non-invasive or semi-invasive modalities for the localization and detection of the epileptogenic focus. So these non-invasive modalities include seizure semiology, which involves the use of signs and symptoms to localize where the seizure is likely coming from. And then the use of EEG, the structural MRI, the high-resolution structural MRI protocol. And then if those are not sufficient, we can now move to the semi-invasive modalities, which include the functional imaging, the radionuclide imaging, and then the magnetoencephalography, which we are going to talk about briefly. These are semi-invasive. Now, with these two groups of modality, if we are still not satisfied, if we are unable to conclude on detection and localization of focal epilepsy, we can now move to phase 2. Phase 2 involves the use of intracranial EEG to precisely localize the site of seizure onset. Now, these two phases of imaging workup constitute the goal is to localize the epileptogenic focus. So this constitutes the first step of preoperative assessment. The second step of preoperative assessment is to determine the location of the epileptogenic focus in relation to critical brain areas, such as the eloquent cortex and the important white matter tracts. And this is achieved using the functional imaging. The functional MRI, which helps in localizing the eloquent cortex, and then the diffusion weighted imaging, which helps in localizing the important white matter tracts. Once this is achieved, Then we will now determine whether we proceed to surgical resection of the epileptogenic focus or not. Now, the condition to proceed to surgical resection, if we are able to determine the location of the epileptogenic focus, is provided the epileptogenic focus is remote from the site of the eloquent cortex or the important white matter tracts. If the epileptogenic focus is well separated, then we can proceed to surgically resect the epileptogenic focus while preserving the important areas of the brain. However, if the epileptogenic focus is close or in the region of the important brain areas, then we cannot proceed to surgical resection. In this case, we will pursue the alternative treatment modalities, such as neuromodulation or what we call the palliative procedure. So this is just an overview of the workup. Now, MRI detection of epileptogenic lesion is actually a three-dimensional challenge that is determined by three factors: the quality of the MRI image, what we call the focus hypothesis, and then the quality of the MRI reader himself or herself. Now, in terms of the quality of the MRI image, the International League Against Epilepsy Neuroimaging Task Force has recommended a minimum standard of MRI protocol, which is called the harness MRI protocol, as the minimum requirement to investigate epilepsy using MRI. And this includes 3D T1 weighted images acquired in volume and with thin slice, 1 millimeter slice, 3D FLAIR images acquired with 1 millimeter slice, and then high resolution 2-dimensional T2 weighted image acquired perpendicular to hippocampal lung axis. This is important because the usual images we acquire are perpendicular for corona to the ACPC axis. But for epilepsy, the images, especially the T2 weighted image corona image, must be acquired perpendicular to the hippocampal lung axis. And then there are also other protocols that are non-mandatory according to the Neuroimaging Task Force, but they may become necessary, such as susceptibility weighted image, which has been made necessary by Wema et al. Because sometimes you may want to detect very small vascular malformation, which the other protocols the other sequences might not be able to detect. So susceptibility weighted image becomes important here. Then contrast enhanced image may be necessary, especially when you are dealing with the epilepsy-associated tumors that we have already talked about. Now, the importance of obtaining, using a good MRI image quality and adhering to the protocol is that sometimes, as we can see in these axial FLAIR images, these FLAIR images was passed as normal because it was acquired with thick slices, 3 millimeter, reconstructed rather with 3 millimeter slices. However, when it was reviewed at 1 millimeter slices, the lesion that was originally missed came into view, which is a focal cortical dysplasia, and it was the cause of seizure in this particular patient. Now, hippocampal angulation, I've already talked about it because this is necessary to delineate hippocampal sclerosis. If the images is not acquired using hippocampal angulation, we are likely to miss many cases of hippocampal sclerosis, especially the subtle ones. Now, the MRI fit system, preferably 3 Tesla MRI is preferred to 1 Tesla MRI. But whatever is available can be used. Like in this case of coronal FLAIR images, that shows this subtle lesion that was passed as unremarkable. However, when the patient when the image was acquired using a 3 Tesla image, the lesion became conspicuous, and this turned out to be focal cortical dysplasia. And it is the so I was talking about the importance of acquiring a good image in improving detection accuracy of focal epilepsy, and that the fact that 3 Tesla MRI is preferably, as illustrated by this example. Now, the other factor that influences that is constitutes a diagnostic challenge in detection of focal epilepsy is the focus hypothesis. And this is the use of seizure semiology and its EEG finding to give us an idea of where the seizure is arising from, and hence the location of the epileptogenic focus. So this will enable us to focus, direct us to the place or to these areas where we focus our energy on. Since some of these lesions are sought to and can easily be missed. So in this case, for instance, so using the focus hypothesis, or if we are, for instance, we are not using the focus hypothesis, we came across this case of Sturge-Weber's syndrome, which was characterized by cortical lesions in the right occipital lobe. This lesions is potentially a potential cause of epilepsy. But however, in this case, the focus using the seizure semiology and EEG might have localized the seizure focus elsewhere and not here. So if we don't apply the focus hypothesis, we will assume that this is the cause of the seizure, and then we will miss this associated finding of hippocampal sclerosis, which might in fact be the cause of the seizure. So using the focus hypothesis helps us to focus on the area of the brain that is likely the source of the seizure, and hence helps us to minimize instances of missing diagnosis. And sometimes, in a case of MRI negative epilepsy, especially in those cases where the lesion is sought to, focus hypothesis will help us direct us to a region where we should focus on, such that even if we identify a subtle lesion, we know, we have a high index of suspicion that this is likely to be the cause of epilepsy. As in this case, this MRI was passed as negative. But using focus hypothesis, it was now discovered that there is actually a lesion in the right frontal lobe, which was missed previously. But using the focus hypothesis, we were able to detect it. Now, studies have tried to examine the utility of focus hypothesis, whether in fact, whether it improves the detection rate of epileptogenic lesion. And it was found that it actually did, especially in the detection of focal cortical dysplasia and hippocampal sclerosis and limbic encephalitis. As you can see, this was obtained using focus hypothesis. The detection rate was almost 80%. And without focus hypothesis, is 50%. And the difference in detection rate is significant, thanks to focus hypothesis. The same thing applies to focal cortical dysplasia. Now, the quality of the MRI reader is also an important factor in determining diagnostic accuracy of focal epileptogenic lesion. And it was found that when given a spectrum of causes of focal epileptogenic lesions, it was found that the detection rate for focal cortical dysplasia and nodular periventricular heterotopia is poor among the general reporting radiologists compared to these other lesions. Now, a major way to improve the quality of the MRI reader is usually in the use of course, apart from training and experience, usually the use of standard reporting checklist to rule out each cause, the important causes of focal epileptogenic lesions, because the spectrum of the important causes are not many. So by ruling out each of the causes, it helps to improve the detection rate. what are the roles of advanced modalities in the workup of epileptogenic lesion, focal epilepsy? Now, some of the advanced imaging and one of the advanced imaging modalities we use are the advanced MRI sequences, such as the arterial spin labeling MRI, which is a form of perfusion MRI. So usually arterial spin labeling shows the epileptogenic focus as an area of hyperperfusion when there is seizure, and an area of hypoperfusion when there is no seizure. So that's why we describe the ictal hyperperfusion and inter-ictal hypoperfusion, because it describes the timeline, the instances where this are shown. Then the diffusion tensor imaging and tractography is also an advanced MRI sequence, which is mainly used for the delineation of the white matter tracts. And then we have the functional MRI, which is used in the identification of the eloquent language areas of the brain. And we've already highlighted the importance of some of this earlier on. Now, this is an image of arterial spin labeling MRI that shows this region of hypoperfusion, inter-ictal hypoperfusion in this patient with epilepsy. And this is an image of MR tractography. And this particularly shows thin splenion of corpus callosum. This is an image of functional MRI that shows predominance of the language area on the right side of the cerebral hemisphere in this case. So, okay, so I was trying to move to the next slide. So here we also have we also talked about the magnetic source imaging, which I highlighted earlier. So magnetic source imaging involves the co-registration of MEG, which is magnetoencephalogram with MRI. Magnetoencephalogram is like EEG, but it's just that in this case, we are using the magnetic field. It involves detection of magnetic field, unlike electric field, which the EEG dictates. Magnetoencephalogram is more, has a higher spatial and temporal resolution compared to EEG, and that is why it is preferred to EEG. So it allows a more precise localization of the epileptogenic zone than EEG. And of course, is also employed in the detection of MRI negative epilepsy. We can appreciate this first image, which is magnetic source imaging. And it shows this cluster of dipoles, MEG dipoles, in the right temporal lobe. And this is usually the source of the seizure. And then, of course, the image below is a PET image that shows hypometabolism, inter-ictal hypometabolism, that corresponds to this location in magnetic source imaging. And then this is a structural MRI, T2-weighted image. This lesion was initially missed because it's so subtle. So if not for the use of this advanced modality, it should have been missed. Can you hear me, please?
Yes, we can.
Okay.
Yes, we can hear you. We can hear you.
All right, my slides. Okay, so there are also other advanced modalities in the diagnostic workup of focal epilepsy. And this is the radionuclide imaging modality, the PET and the SPECT. So the role of nuclear medicine imaging is actually to confirm the location of epileptogenic zone, especially in a case of MRI negative epilepsy, or if there is a discordance between the findings on EEG and structural MRI. So PET or SPECT comes in to resolve that discordance. That's the role of SPECT and SPECT. Usually in PET, epileptogenic zone shows up as area of hypometabolism when there is no seizure. So usually obtained in the interictal period, not in the ictal period. It is not obtained in the ictal period because of the low temporal resolution of SPECT. So SPECT is usually obtained in the interictal period. There is also a software called statistical parametric mapping, which integrates PET with MRI. And this has also been proven to enhance location detection of epileptogenic zone. Now, for SPECT, we can have ictal SPECT and interictal SPECT. We have ictal SPECT during seizure because SPECT has a high temporal resolution. It can capture the seizure activity almost real time. So during seizure, PET epileptogenic zone shows up as hyperperfusion on SPECT. And when there is no seizure, that is interictal now, epileptogenic zone shows up as hypoperfusion. Now, there is a technique called subtraction ictal SPECT co-registered to MRI, and that's what we call SYSCOM. Now, what happens here is that the data from the interictal SPECT is subtracted from the ictal SPECT in order to maximize the contrast, the detection of the epileptogenic zone. And this helps to reduce, it makes it more objective. It reduces subjectivity, and then it reduces inter-reader variability. That is why SYSCOM is such an important modality or technique in SPECT imaging. So in this image, you have hippocampal sclerosis on the right, which shows up on this PET image as an area of interictal hypometabolism, because it's obtained when there is no seizure. And then it shows up on the SPM image, that's the statistical parametric mapping, as this abnormal area of metabolism. Yeah. Now, this case actually is an interesting case, a little interesting case, because it's a case of it's a case of mesial-temporal sclerosis in a patient with concordant seizure semiology and EEG. And functional MRI was actually done for this case with the non-eloquent area being in the area of the epileptogenic zone. So because the non-eloquent area is here, which means the eloquent area is remote from this epileptogenic zone, this patient had surgical resection and became seizure-free afterwards. So this is another case, interesting case, in which a flare of drug-resistant MRI negative epilepsy, in which a flare image revealed no focus of epileptogenic focus. But this patient went on to have SPECT. This is ictal SPECT, and it shows area of hyperperfusion in this right frontal lobe. And then there is the interictal SPECT that shows area of hypoperfusion. Now, SYSCOM was obtained, which highlighted this perfusion abnormality and localizes it to the right frontal lobe. This patient had a functional MRI that shows the involvement of the eloquent area by this lesion. For that reason, the patient could not proceed for surgery because surgery will result in disastrous consequences. Rather, the patient had neuromodulation, which is an alternative treatment in this kind of case. Now, radionuclide imaging, especially PET and CSTEM, has been shown to have high sensitivity for the detection of temporal lobe epilepsy. However, their sensitivity in detection of extratemporal lobe epilepsy is low. But SPM, that's a statistical parametric mapping, has been shown to actually be more sensitive in the detection of extratemporal lobe epilepsy. ICTA-SPECT is more sensitive than PET for the detection of MRI negative epilepsy or the non-lesional epilepsy. Now, multimodal imaging is actually the current practice in the imaging workup of epilepsy, especially the drug resistance epilepsy. And the goals of multimodal imaging include to optimize detection of the epileptogenic zone and localize it, and then to identify concordance between the various imaging modalities, as well as, of course, to determine its spatial relationship to the eloquent cortex in order to know whether to proceed for surgery or not. And then it is also important to guide therapeutic intervention. Now, the multimodal imaging is usually delivered in form of multimodal image integration. So using a software or an application that can integrate all the imaging modality in a common 3D space so that we can analyze MRI, structural MRI with magnetic source imaging and functional imaging alike. We can analyze all the modalities, diagnostic tools in one place. So it makes it easy for us to evaluate these findings from each of these modalities simultaneously, and then to determine if there is concordance. And this is what the International League Against Epilepsy Neuroimaging Task Force has been able to demonstrate and encourage in the practice of epilepsy care, especially for tertiary centers that manage epilepsy. The use of multimodal image integration with image.
Sorry to interrupt, Dr. Efidi. We're pressed for time. I don't know if you are almost done yet.
Yes, I'll soon be done in another 8 minutes.
All right.
Thank you. So the role or the utility of multimodal image integration with pre-processing is illustrated in slides. So, this is a case of drug resistance epilepsy, which flare-weighted image were acquired, and it shows this focal hyperintensity with transmantle sign, which is characteristic of focal cortical dysplasia type 2. This was not so conspicuous on the T1. Now, PET imaging was acquired, as well as arterial spin imaging in this case. PET imaging, however, did not show abnormality here, was not able to detect it. However, arterial spin imaging was able to show area of interictal hypoperfusion in the right frontal lobe, which is also indicated here in the ASIA image. Now, there is a software called MAPS and FLAT1, and these are MRI post-processing software that tries to maximize detection, the conspicuity, especially of inconspicuous MRI findings, especially detection of MRI negative epilepsy or subtle cause of epilepsy. So this was employed in this case. It's an advanced post-processing algorithm called FLAT1. And this was able to accentuate or highlight the focal cortical dysplasia and localize it to right frontal lobe. Using this yellow cross, we were able to pinpoint the location of the epileptogenic focus. Now, there was also an advanced post-processing done on arterial spin labeling image. And we have asymmetric index. So this asymmetric index was also able to highlight the location of the epileptogenic focus. Also indicated by this cross, red yellow cross. Now, all of these modalities were co-registered in order to pinpoint precise location of this epileptogenic focus. Functional imaging was done. Functional MRI was actually done to show that this lesion was far away or separate from the important language area, the cortex. And this patient actually proceeded to have surgical section. Okay, so this is another interesting case of MRI, investigation of MRI negative epilepsy. This lesion, which is very subtle, was actually missed initially. Yet, seizure semiology and EEG pointed to an epileptogenic focus in the frontal lobe. So for that reason, advanced multimodal image integration with advanced processing was utilized here. And using the MAP software or the MAP technique, the lesion was localized in the left frontal lobe. Magnetic source imaging was also employed in this case, and this is a corona weighted T1 weighted image, free sweep, a MEG, and this shows cluster of MEG dipoles, also localizing the seizures onset to the left frontal lobe. This is a 7 Tesla MRI, susceptibility weighted 7 Tesla, that shows a subtle subcortical hyperintensity in the same location. Now, intracranial EEG was done in this case. The purpose of intracranial EEG is twofold. One is to precisely localize the seizure onset zone, which corresponds to the epileptogenic zone, and also to precisely delineate the eloquent area. Now, the reason why this was done was because the eloquent area was in the vicinity of the seizure onset zone. So the use of intracranial EEG became necessary in this case to precisely delineate this, the seizure onset zone, the epileptogenic zone, from the eloquent cortex. So the seizure onset zone is highlighted by the hyperintense signal. And of course, the location of the confirmation of that location was also highlighted by the red spheres based on the intracranial EEG done. Was also able to localize the language area or the eloquent cortex close, but not exactly the same point as the epileptogenic focus. So this is a 3D image that combines all the findings such that the epileptogenic zone was localized to this area, whereas the eloquent area were localized not exactly the same point, but a little close to it. This patient still went ahead to have surgical resection, but under intracranial EEG monitor, neuronavigation. And interestingly, this patient became seizure-free without neurological deficits. So in conclusion, neuroimaging, especially MRI, plays a key role in the pre-surgical management of drug-resistant epilepsy or medically refractory focal epilepsy. And accurate pre-surgical localization of this epileptogenic zone is critical for positive post-surgical outcome. The current pre-op workup of drug-resistant epilepsy is based on multimodality approach, which combines the electroclinical and multiple imaging modality in order to improve detection of especially the MRI negative epilepsy. Multimodal image integration also with advanced post-processing techniques has also added in enhancing the diagnostic yield of multimodality image and improve post-surgical outcome. Thank you for your attention.
Thank you very much, sir, for the presentation. It was really a very detailed and enlightening session. Thank you so much, sir, for the privilege. We have 2 questions on the group. I don't know if you have any other questions, but if you have any questions, you can raise up our electronic hands. We can make it snappy because we are pressed for time. But let me just read out the 2 questions we have on the group chat. The first question from Udo Chibweze is, you mentioned tuberous sclerosis on more than one occasion while describing features of Sturge-Weber syndrome. I wish to ask if it was a mix-up or you did mean tuberous sclerosis while your slides had SWS. The second question from Dr. Bande is asking, how do you explain hippocampal angulation ACPC to your radiographer so that they can acquire what you want, or their basic training is sufficient to help them understand what hippocampal angulation protocol is? Also, is there a role for AI in the imaging of epilepsy as at today, sir? So I think you can attend to those questions. If you have any other questions, you can raise up our electronic hand and we would ask. Thank you.
Okay, thank you for the questions. The first question is obviously a mixed up. If I attributed the features of tuberous sclerosis to Sturge-Weber syndrome and vice versa. For Sturge-Weber syndrome, I described the presence of cortical and subcortical hypointensity with atrophy. In the right, okay, I think let me just move to the particular image just to clarify. Sorry. Okay, I think this is the image. So here, this is a classic image representing tuberous sclerosis, which is in this case characterized by cortical atrophy and cortical and subcortical hypointensity signal void in the right occipital loop. This usually, when you do CT, gives us the gyriform or cortical calcification. So this is Sturge-Weber. Tuberous sclerosis is this other case on the left, which is characterized by cortical, multiple areas of cortical hyperintensity, which represent tuberous tubers. I think that's what I meant to say. Are we together, please?
Yes, we are. You can address the second question, sir.
Okay, so for the second question, hippocampal axis and what's a minute?
The question is, how do you
Yes,
explain
I know.
hippocampal angulation?
Yes, I'm just trying to show the image. Okay, maybe I don't really have a particular image. So the usual axis in which MRI images are acquired is the AC-PC axis. AC is the anterior commissure, PC is the posterior commissure axis. So the line of axial acquisition is along the AC-PC axis for axial images, axial acquisition. That is the normal, the conventional axis of acquisition, which the radiographers are familiar with based on their training. Now, the hippocampal axis is another axis different from this conventional axis. But in this case, it is acquired along the axis of the hippocampus itself, the long axis of the hippocampus itself. So, and this is necessary for ease of detection of hippocampal sclerosis. So we actually, if we are going to explain this to the radiographer, ideally it should be part of their training because this involves techniques, MRI acquisition techniques. So a radiographer that is conversant with MRI imaging should also be familiar with the hippocampal axis. So we don't really need to teach them. Really, they should be familiar with it. Otherwise, they may need further training. And actually, there are opportunities for training. That's for those that are practicing in epileptic centers. So if a radiographer, for instance, is not familiar with that, the radiographer will need further training on that. But a radiographer should be familiar with it because there are different axes of image acquisition. It's not just the conventional one. And they must have been taught as part of their training. So it's not something we need to train them. Of course, we need to let them know. We need to tell them that this is what we need. They should be familiar with it as part of their training. I hope I've been able to address the question.
Yeah, I think so. I think so much. Thank you so much, Dr. Efidi.
Okay, thank you.
I think,
so if there are other questions, I will be glad to address.
Yeah, I do have a question.
Okay, please have your question quickly.
Yeah, sorry, Dr. Efidi. Thank you so much for a great talk. You mentioned about arterial spin labeling being complementing in the diagnosis of epilepsy. Like, are you doing it commonly in your setting for that diagnosis of epilepsy?
Okay, thank you very much for the question. Actually, arterial spleen labeling MRI is one of the advanced imaging modalities that are used in the diagnosis of epilepsy, but it's not meant to be done routinely. It's meant to be done at a second level, at a higher level, especially if we are unable to diagnose focal epilepsy with structural MRI based on the harness protocol by International League Against Epilepsy Imaging Task Force. So if we are not able to conclusively detect the epileptogenic zone, then we can proceed to arterial spleen labeling. It's not a routine modality because it's an advanced modality, but it can also be done really as part of the MRI acquisition. No, we don't do it routinely I don't do it routinely in my center. And also I'm not in epilepsy specialist center. So I don't routinely do it. I hope I've been able to answer your question.
Yeah, thank you.
Then one other thing I want to add is that arterial spin leveling technique is particularly useful in children. I'm not sure I mentioned it. And the reason is that in children, the use of MRI is very poor, has very poor sensitivity. Because in children below 2 years of age, they are still going through myelination. Their myelination has not been completed. So MRI is very poor in the detection of epilepsy. So in this case, it can be supplemented by arterial spin labeling. Although the other modality that is also good is the radionuclear functional imaging. But you know, radionuclear is also radiation, is invasive, injections and all that. So we want to avoid all of that in children. So that is why arterial spin leveling imaging is a diagnosis of choice in children, especially where MRI fails to identify the epileptogenic lesion.
Thank you very much, sir. We want to thank you once again for the beautiful lecture. We have been, we have learned, we have relent, and we have been more enlightened even to practice radiology in a better light. So we have come to the end of today's seminar. We want to thank our speaker and our lecturer, Dr. Richard Efidi, for the privilege of giving us the lecture. We say thank you so much, sir. We really appreciate it. And we would also want to inform everyone of another opportunity like this, which is coming up very soon. We have an MRI masterclass by the Smart Africa Network, which is another opportunity, a great opportunity like this. Is a 2-day masterclass, which we'll be holding from the 24th to the 25th of July. That's this month. That's in a few days' time. It's an opportunity again to actually come and learn more about MRI. It's for radiographers, for radiologists, for people who are in training and all of that. So it will be holding at LASUS in Lagos State University Teaching Hospital. There will be a session that would first be holding at the Redeemers Health Center, which is actually an arterial spin labeling boot camp. It will be focused on ASL. That's the first part of it, which will actually happen on July 22, before having the 2 days that will be in Lagos. We'll have an ASL boot camp, which will also be an opportunity where we'll have experts come to teach us about ASL and the different techniques and data processing. So this is another opportunity again for us to come to learn about MRI neuroimaging, and I'm sure that we'll not regret it. If we need more information on how to register, even though registration has closed, but I think there should still be some allowance for whoever wants to register, even at this point. I think we can have the information put on the chat box so that we can register. So once again, I'll say thank you very much. If you have any more questions.
Sorry, there's one more question. Professor Ogo,
Okay.
ask the question in the chat
Okay.
box, please.
Oh, sorry.
Thank you.
Okay.
Oh, I didn't
Okay.
get that.
Should we take more questions?
Yes, please. Let's take
Okay.
more questions.
Okay, sir. Okay, sir.
I'm glad
So we
to
have
do it.
2 questions here. We have a question saying, are you saying MRI is not useful in children below 2 years? But I think
Okay.
Dr. Richard Efidi has already answered, said it's still useful in children, but it shows poor sensitivity due to incomplete myelination below 2 years. Above 2 years after completion of myelination, MRI becomes more sensitive.
Then I want to add too, I also want to add one more point. If we must do MRI below 2 years of age, based on the harness protocol, which recommend the use of 3 mandatory sequences, T1 is actually the most sensitive, for below 2 years, and is not so much affected by the presence of ongoing myelination. However, FLAIR and T2 become very poor in terms of their sensitivity. So with T1 weighted imaging, we may be able to detect a lot of cases of epileptogenic lesions in children below 2 years. And usually what happens is that if the outcome of investigation is not conclusive, the child can remain controlled on anti-epilepsy drug. If the child can be controlled by anti-epileptic drug, then usually they can wait till they are more than 2 years for a more accurate detection and localization of the because the accurate and precise localization of the epileptogenic lesion is very important. It's critical. If anything goes wrong, the surgery would be a bigger problem to the child than the epilepsy itself because of risk of complications. So that's why we want to examine thoroughly before we come to a conclusion about surgical management, especially. So I hope I've been able to throw more light in that regard.
Thank you very much, Dr. Efidi, our professor in diaspora. Thank you so much. We appreciate your time, and thank you for those who have stayed up to this time. We have overshot our time by 30 minutes, but I thank you for those who have stayed this long, and we look forward to a greater edition next month. Thank you, everyone. Have a wonderful day.